Potter, Associate Professor of Medicine at Harvard Medical School, and Director of the Women's Health Center at Beth Israel Deaconess Medical Center, and Director of the Women's Health Program at Fenway Health. It's a pleasure to introduce our panel for today. Thank you for joining us. I'd like to introduce first Dr. Scott Leibowitz, Head Child and Adolescent Psychiatrist in the Gender and Sex Development Program at the Anne and Robert H. Lurie Children's Hospital of Chicago, and Assistant Professor of Psychiatry and Behavioral Sciences, Northwestern University Feinberg School of Medicine. To his left, Dr. Catherine Barretts-Dalk, Chief Resident, Department of Psychiatry, Hospital of the University of Pennsylvania. And next, Dr. David Malbranche, Primary Care Physician, University of Pennsylvania Student Health Services. To his left, Dr. Melanie Davis, President of Honest Exchange. And then Dr. Jason S. Schneider, Associate Professor, Division of General Medicine and Geriatrics, Emory University School of Medicine. And Dr. Carrie Roth-Baer, Associate Professor in the Departments of Community Health and Preventative Medicine and Medical Education at Morehouse School of Medicine, and Associate Director of Educational Leadership for the Satcher Health Leadership Institute. Welcome again. And let me pose the first question. What are the similarities and differences between the following terms: sexual behavior, sexuality, sexual health, sexual orientation, gender identity, gender expression, gender nonconforming, transgender, sexual identity, and differences of sex development? Dr. Malbranche, why don't we start with you?
The first one was?
Sexual behavior.
Well, I mean, sexual behavior kind of speaks for itself, and I think probably the best example of that would be kind of the term men who have sex with men, talking about kind of who you're having sex with, but it can also be specifically the behaviors, whether it could be oral sex, anal sex, vaginal sex. I think when we talk about behavior, it kind of encompasses all those things.
And how does that differ from sexual orientation? Dr. Dalk?
Well, sexual orientation, I think, can imply a number of different things. It can imply sort of a general partner preference, who people may prefer to partner with in terms of their emotional attraction, physical attraction, romantic interest in other people. It can also imply an identity in terms of how the person identifies themselves and what other groups they might identify with, as opposed to an emphasis on the behavior that Dr. Malbranche was describing.
And Dr. Davis, could you jump in here and talk a little bit about gender identity and gender expression?
The difference between the two?
If you could.
So your identity is an internal sense of who you are as a gendered person, somewhere on the spectrum. And your expression is what you show to the outside world. So some of those things are obvious, like clothing that we might choose, but some of them are subconscious behaviors, voice patterns that the world sort of chooses to interpret for us.
And Dr. Leibowitz, the term gender nonconforming, can you say a little bit about that?
I think gender nonconforming refers to a broader experience or a broader application of individuals whose gender expression does not necessarily conform to what society might expect based on their anatomy or the secondary sexual characteristics that they may have. So it's a much broader term used that wouldn't necessarily mean someone's experiencing an internal identity disjunction between their anatomy and how they feel they are.
And how would that be similar to or differ from transgender? Dr. Schneider?
So gender nonconforming is more of an umbrella term to define people who have a variety of different identities, including transgender. There are many people that have gender nonconforming identities that don't necessarily adopt the term transgender.
Thank you. And Dr. Roth-Baer, if you could just say a little bit about sexual health as well.
Sure. So sexual health, and I'll tie it to sexuality. A lot of times we think in terms of the behavior or the anatomy, and sexual health really goes broader than that to the whole being. So really that kind of essence of who I am, including body image and self-esteem and sexual sexual self-esteem. So you kind of get into not only those attractions and that orientation of who or what I'm attracted to, and how I express myself, but also how I feel about myself, how I engage with other people in relationships. And I think sometimes that's the piece that gets missing in sexual health, is we're so keyed in on the behaviors or the anatomy or what behaviors are being engaged with of other people, that we forget about that relational kind of emotional connection.
Thank you. So we've been talking about a number of terms that have to do with sexuality and gender, and I'm wondering now if we might just switch a little bit to differences of sex development. Dr. Dahlk, if you could say a few words about what we mean by that term and whether that corresponds to an identity or something different.
So differences in sex development is an umbrella term that describes a group of heterogeneous congenital conditions that affect sex differentiation. And this can happen at multiple levels, whether we're talking about sex chromosomes, internal reproductive structures like gonads, for example, or external anatomy. And sex differentiation can vary at any point in the formation of any of those structures. Differences in sex development, or DSD, sometimes do correspond with a person having a different gender identity, gender expression, sexual orientation, or sexual identity, but it really is distinct from those things. It is a biological sort of fact of what that person's body is, and may or may not correlate with what their behavior is or their sense of their identity may be.
Thank you. Is there anything else relating to this question that any of you would like to add?
The one distinction I'd like to make is that we have all of these layers to our identities, and sometimes they work together and sometimes they don't work together. And I think that that's one thing in the health professional field and arena and medical education, is that sometimes we like to put people in boxes and make assumptions that all levels of identity match up. And so, somebody who may identify, you talked about the term men who have sex with men, may or may not identify as gay, may or may not identify as heterosexual. So how we pick and choose these different labels and make these distinctions is really important in how we connect with our patients.
Especially from a clinical perspective, sexual orientation is often equated with sexual behavior, and that's oversimplifying the terms.
I also think it's important that we don't apply clinical terms and terms used in the literature and terms used in the research to mean that those are terms that patients prefer to use, and those are terms that patients feel comfortable using, or even terms that patients understand. And so clarifying, especially with terminology that's always evolving, what the patient feels is most applicable to them, even if it differs from what we necessarily have said here as how it exists in the literature, is an important distinction to make.
Thank you. I'm wondering if a few of you might share how you do that in an interaction with a patient, what terminology you would use with the patient, how you might query the patient regarding what terminology they would prefer to use. Anyone?
Well, one of the earliest ways that someone feels welcomed into a practice is often on a website. So if your language on your website is binary, that patient already knows, I maybe need to use a little caution. If they walk in the door and the forms that they fill out are limited to male, female, or maybe sometimes there's a T, as opposed to just a gender and a blank. So let the patient identify the way the patient wants to, maybe offering pronouns that, a blank, so which pronouns do you choose? So anytime you put a letter or something concrete on that paper, you're automatically limiting the options that the patient has and the welcome that they will feel.
And how about when the patient gets beyond the more objective look at the office and enters into it and is starting to interact?
I think it's kind of simple questions, and it starts off, and this is simple enough, but like a handshake and touching somebody, because a lot of times you'll see providers will get uncomfortable if they see somebody who anatomically corresponds with a certain gender, but then their gender performance or how they express is a little bit different. It'll make people uncomfortable. And so they may not do the traditional things like shake their hand or just touch them or listen to their lungs and have a hand on their shoulder, some things like that. But I think one of the important points is kind of providers have to do this dance where you're doing a clinical assessment, but then you also want to be respectful of the patient's identity, how they see themselves. So asking a simple question to say, how do you prefer to be identified? Or what pronoun do you prefer to use? It always seems like it may be uncomfortable to ask that at the beginning, but I guarantee you most patients are really appreciative of that because it gets that elephant out of the room at the beginning, and then you can move forward. And you can educate the rest of the staff about that, because a lot of times you may know this, and although someone says, well, his name on the chart says Alex, and it's like, well, no, she prefers to be called Alexandria. And so to be able to pass that education on, but the simple thing and the end all of it is just to ask the patient first and let them tell you how to proceed.
That does require a change in mindset, because I think many providers are used to looking at the demographic sheet. Oh, hi, Mr. Jones, I'm Dr. Schneider, nice to meet you. And so it requires you to change the order, to first ask the person in front of you how they prefer to be addressed.
And you can use that. We actually have in our electronic medical record system, if a patient does identify as something different from their birth gender that they've been assigned, there'll be an asterisk and they'll make sure they change that in there. And all it takes is a simple meeting with somebody at the front desk to kind of get that changed. And so from then on, when the provider will actually open up the patient's chart, they'll see, and then they can know from then on in.
And to take that to the next level further, it's also important to understand the context in which some individuals may want to be referred to in a certain way, recognizing that maybe some adolescents may not feel comfortable being identified in their affirmed name or pronoun when with parents who might not necessarily accept them. And so taking those preferences and then even asking more open-ended questions beyond that and saying, would that change in any specific context? And then educating the staff further. It takes a lot. It's obviously more complex when you get into having to make different plans for different contexts. But that's what really, really separates out the intuitive, comprehensive, and competent physician from those who make other patients and patients just in general not feel welcome.
I would just add that it's important to have a policy that applies to all patients. Because if you only apply the policy when you think someone doesn't sync up, then that's not treating everyone on an equal basis.
And what has the experience been in the group with asking these questions generally to everyone? Has there been surprise from those who do not identify in these various ways, and how does one handle that?
I've had it in my work with one-on-one, just asking questions, and people will be surprised if they're cisgender people and they've never been offered the option actually to think about their identity, really. So yeah, they express surprise, but if you say it's my policy to just ask the same questions for everybody that I see, then they kind of roll comfortably with it.
Would you mind just defining what you mean by cisgender?
Someone whose internal sense of gender identity correlates as we would expect it to link up with their biological sex.
Wonderful, thank you. This is all very complicated, and it seems inevitable to me, especially as people are learning to use these terms in new ways and learn how the patients would prefer to be addressed, that there will be errors that are made that could potentially be hurtful to the patients. And I'm wondering what your suggestions are for how to handle those moments.
I think that's a really important point, which we're sitting here today talking about terminology that may change tomorrow, and how we stay open to learning from the patient. How we may use language or we express that we're interested in knowing and understanding, and that we may not always have all the answers. And in most cases, we're not always going to have all the answers. And so letting the patient teach us, letting the patient share that language with us or share that experience, and being willing and receptive to take that information and use that information to the patient's benefit.
When you get a nonverbal cue that you've made a verbal misstep, apologize. And then, as it's suggested, ask for a correction in how they would prefer to be addressed. It's surprisingly simple, but it makes a big difference in developing rapport with someone.
I had a patient who is a trans male, and his partner doesn't identify with any gender. And so sometimes, but presentation was of a female, so I remember I slipped a couple times and said, "How is she doing?" And he was always quick to correct me, them. And he just corrected me each time, and I said, "I'm sorry." And I just apologized and moved on. It's about, like, as a provider, being humble and realize that you may not get it right all the time, or you may trip up. Even those of us that consider ourselves, quote unquote, experts or someone who's knowledgeable in the field, we can still make mistakes with these things. Sometimes we're human.
And can one of you say a little bit more about what the impact might be on a patient when it does not go well? When something that is a misspeak lands, why is that of particular relevance to people who identify in the various ways that we've been talking about?
Especially with the layers, the petals on the rose that we've been talking about, socioeconomic status, immigration status. So those can often be barriers to disclosure of identity and behavior, that verbal misstep from a provider can just add another barrier that shuts a person down and will not facilitate them sharing what can often be very important health-related matters with a provider.
I think the essence of any healthy doctor-patient relationship is trust. And I think that when a doctor has a misstep, and the intention behind it is perceived as one that is not welcoming, that is disrespectful, that could lead that patient to not come back. That could lead that patient to then feel maybe other doctors are all taught this way to not make me feel welcome. Maybe doctors are not going to understand me. And that could lead them to not get treatment for very serious issues that they need help for. That could lead them to suffer in silence for issues that they don't have to do so with. So that trust aspect of care is crucial, as it is applicable to all patients, when really helping people get answers and get help and get treatment for the issues that they need help for.
I think that was really important because it's not just the trust with that patient provider, but it's also the trust with the medical system on the whole. And we know that we've seen a lot in health disparities, particularly for LGBT populations, because of the distrust in the medical system, because of a bad experience. And so I think that there's a huge opportunity to not only build that trust one-on-one, but to bring patients back in so that when you talk about that renal case, there may be that lesbian who comes in that doesn't need a sexual history because she really just needs to have the kidney function checked. And we forget that when we have boxes checked, that sometimes a cough is just a cough and it's not an STD.
Right. There was a but a participant in a focus group we did years ago in New York City who had moved to New York from Texas and had no insurance, nothing, and couldn't find a clinic. And his symptom, he had anal itching for a few weeks. And as a clinician, when you have anal itching, it could be basically anything from something as simple as hygiene versus, warts, herpes, to cancer at the end of the spectrum. And he went to see a provider, and the provider said, "Do you have anal sex?" And he said, "Yes." And she said to him, "Well, the anus really isn't made for that." And he said, "Yeah, I know, but it's already done." So, and what happened was that he told the story was that he left the office and didn't come back. Like, she stepped out to go do whatever before he gowned up, and he just left. And as he sat there in the focus group, I asked him, I remember saying, "Well, have you been seen for this yet?" And he said, "No." And so he was still having the symptoms, but preferred to shoot himself in the foot and leave the clinic rather than subject himself to that kind of judgment. I think it's a part trust, but it's also part judgment, because we're seeing this position of power that we're in as clinicians and supporters and nurturers and supervisors, and any kind of small judgmental thing that we say is going to have a profound impact on how they access care in the future.
I think some of that can be reflected in terms of what gets charted. So you can have a conversation and not fill in every box, at the first visit, or even considering body language. Because it's funny when you work with students who are learning and they're very focused and their body language is great, but then if you're in practice and you're filling out a computer screen, suddenly your attention is there, and this person might be disclosing very personal things about their sexual identity or their sexual behaviors. And if I'm glued to the computer screen typing everything down, that's just going to shut down the level of disclosure.
And even forms that exist, like what you just said, combining what you two both said, it made me think about even treating children or adolescents who have parents who are same gender. If you have a form that says father's name, mother's name, parents who come in who may not necessarily feel that they are a mother and a father may feel uncomfortable with the pediatric practice for their child. Staff may not make that same gender couple feel welcome. And it also sends a message to the child that their family is not necessarily the right family. So this doesn't just extend to the people we're working with, it extends to their families, it extends to just society in general.
To add another level of complexity, let's think a little bit now about how these terms intersect and interact with categories of socioeconomic status, education level, culture, ethnicity, and immigration status. Anyone want to jump in on that one?
Well, I think it kind of goes back to the comment I was making earlier about we have human beings who we are treating who have multiple layers to who they are. I mean, I think of it in terms of a rose, because I don't really like the onion analogy, of multi-layers to people. And different aspects of that identity or different petals are going to present at different times. And how we learn from and ask those questions in ways that allow these different levels of identity to present themselves. So maybe my culture comes out first before who I'm attracted to or the relationship that I'm in, or maybe I'm not sexually active, or maybe that's not the priority in my identity. So how I take all of these aspects and how we as health practitioners recognize the multiple aspects to our patients' identities and allow them the space to reveal those pieces.
I think that different cultures, different ethnicities have different meanings behind what gender roles should be or shouldn't be. Sometimes those intersect with mainstream American culture. Sometimes those are different. And the key to the question, the key to understanding the question as far as I see it, is to really, again, not make assumptions and not make assumptions that someone's sexual identity or gender identity necessarily is something they prioritize over their ethnic identity, which is something they might prioritize over their racial identity. It's each person's like a rose, and everybody comes at the meaning of gender and the meaning of sexuality from a different perspective and a different standpoint, and based on their upbringing and based on how they've seen the world and socioeconomic status, immigration. These are all issues that add diversity and complexity to the individuals we see. So again, just not assuming that someone sees gender and sexuality in the way I may see it.
And each of those factors can affect the degree of comfort that a person has in sharing these various issues with a provider. And so I think providers need to understand that they may not get the whole picture about the identity or orientation or behavior of their patient. But if you're opening yourself up to those discussions, cues on the walls in your exam rooms or conversations that you have, hopefully that patient will then, despite those barriers and those differences, feel comfortable sharing concerns with you at a later encounter.
And thank you so much for joining today.
Thank you.